Hello. I'd like to thank DTRF for the opportunity to describe a new study that we have recently launched. This study evaluates the association between desmoid tumors and pregnancy, and specifically asks questions about the impact of a desmoid diagnosis on family planning. For nearly 190 years, the association between desmoids and pregnancy has been recognized. In 1832, John McFarlane reported an organized sarcomatous tumor between the layers of the abdominal wall in women who had children in a report published from the Glasgow Royal Infirmary. Yet, despite this long recognition, very little data have been gathered. Naturally, there's a concern about progression during a current pregnancy or recurrence with a subsequent one. Yet there are limited data to guide women with desmoids and their treating clinicians. To address this knowledge deficit, we published a multi-institutional retrospective analysis of recurrence and obstetric risks in 2014. The objectives of our study were to evaluate women with desmoids in 3 different clinical scenarios: those who developed desmoid fibromatosis during or shortly after pregnancy, those with a prior history of either an unresected or an incompletely resected desmoid that was still in place during a subsequent pregnancy, and those who had had a completely resected desmoid without recurrence who became pregnant. We wanted to identify several disease-related risks, including risk of progression with watchful waiting, risk of recurrence after resection, and risk of recurrence during a subsequent pregnancy. Our study cohort of 92 women were gathered from 4 high-volume institutions in 4 different countries: Istituto Nazionale di Tumori in Milan, Institut Gustave Roussy in Villejuif, Princess Margaret Hospital and Mount Sinai Hospital in Toronto, and Brigham Women's Hospital and Dana-Farber Cancer Institute in Boston. We included women with a diagnosis of desmoids and pregnancy either before, during, or after a desmoid diagnosis. We excluded women who had an FAP-related desmoid tumor and those with infantile fibromatosis, Palmer, or plantar fibromatosis. Our key findings are summarized in this table. For women with a new diagnosis of desmoids during or shortly after pregnancy, the risk of relapse after a complete resection was only 13%, but the risk of progression with watchful waiting was 63%. 11% of women were able to experience a spontaneous regression, and overall, 52% of women could avoid an operation. For those with a previous diagnosis of desmoids who became pregnant, the risk of a desmoid recurrence or progression was 42%. Multiple lines of active treatments were needed for 6% of women, and spontaneous regression was noted after initial progression in 7%. There were no significant obstetric risks, although one woman did require a change in her plan for delivery from a vaginal delivery to a cesarean section due to the presence of a vaginal wall desmoid tumor. Our new study will evaluate, again, desmoid tumor and pregnancy, and specifically look at the effect of pregnancy on disease control and the effect of diagnosis on pregnancy history. This will again be an international, multi-center, retrospective observational study. The goals of the study are to define management of desmoid fibromatosis in women diagnosed before or during pregnancy, to analyze the oncologic outcome during and after pregnancy, and to assess potential obstetric risk and decision to interrupt or avoid pregnancy after a desmoid diagnosis. Our primary outcome is proportion of women with disease progression during pregnancy. We will look at progressive disease by RECIST criteria within 1 year postpartum in women with previous stable disease, and local recurrence detected during pregnancy or within 1 year postpartum. Secondary outcomes include time to progression during pregnancy from date of conception, spontaneous regression, proportion of women shifting from active surveillance to active treatment within 1 year postpartum, rate of spontaneous or induced abortion, and rate of obstetric or delivery complications. Our study population includes women over the age of 18 with desmoid fibromatosis with a history of concomitant or subsequent pregnancy between January 2000 and December 2020. We will again examine 3 groups: those with desmoid diagnosed during pregnancy, with macroscopic disease in situ at the time of pregnancy, either from a plan for active surveillance or incomplete resection previous to pregnancy, and those who had a completely resected desmoid without clinical evidence of residual or recurrent disease at the onset of pregnancy. To establish a denominator and to understand some of the challenges of the impact of diagnosis on family planning, we will look at all women with desmoids diagnosed during a fertile period, when they're fertile, and treated during that same time period. Specifically, we will investigate any possible decision to avoid pregnancy after a desmoid fibromatosis diagnosis. In this study, as opposed to our prior study, we will also include women with an FAP-associated desmoid, but we will analyze that cohort separately. Our participating institutions include the same investigators from Milan, from Sylvie Bombolo's group, who's now at Institut Curie in Paris, University of Toronto, and our group in Boston, as well as in Padua. And patient advocacy groups will play a key role in bringing patients into the study. We will exclude individuals with infantile fibromatosis or plantar or palmar fibromatosis. The data points that we will gather include characteristics such as age, tumor size, site of origin, including abdominal wall, extremity, intra-abdominal or other, different treatments, including surveillance, radiation, limb perfusion, different types of surgery, including the date of surgery and margins, and various types of systemic therapy, including cytotoxic, hormonal, anti-inflammatory, targeted, et cetera. Outcomes include recurrence or progression and follow-up. And we will also collect data on pregnancies, including number, abortions, whether spontaneous or induced, type of delivery, cesarean or vaginal, pregnancy complications, including preeclampsia, eclampsia, diabetes, intrauterine growth retardation, and placental complications, as well as labor complications, including dystocia, hemorrhage, fetal distress. Importantly, in this study, which is different from our prior one, we will conduct telephone patient interviews to gather patient perspective. Questions that we will include in the study include, have you had a pregnancy during or after your diagnosis of desmoid tumor? At the time of desmoid diagnosis, were you fertile? If fertile, after diagnosis of desmoid, have you decided to postpone a pregnancy? If so, was this related to the diagnosis of desmoid? After the diagnosis of desmoid, have you interrupted a pregnancy? And if so, was this related to the diagnosis of desmoid? And finally, after the diagnosis of desmoid, have you decided to avoid pregnancy? And if so, was this related to desmoid? Some of the logistics for external patients include getting remote consent, but we will need to have collected signed forms that will be sent by mail if they're not seen in person. Patients in the United States can be enrolled either through our institution or through DTRF. There will be a telephone interview, as I mentioned, and all data will be captured on a secure red cap form for investigators, and there will be data transfer agreements in place for anonymized data. We will collect radiology reports to extrapolate tumor dimension and ask that patients upload their pathology reports, though we will not conduct a central pathology review, which may somewhat impact some of the accuracy, though I suspect that if there are any pathology or any diagnoses in question, we would just exclude those. So thank you for your time. I'm happy to take any questions in the live format.